Welcome back, everyone. We're going to continue down the newborn and neonate series and discuss some congenital defects to be aware of. While prehospital management or treatment of congenital heart defects is going to be solely based on supportive care and supporting oxygenation, ventilation, and circulation, it's important that we're able to recognize some of these disease processes as it's going to complicate care for the newborn while we get to the receiving facility. And it's really important that we assess these underlying presentations, and so that the receiving facility can be aware and have prepared the appropriate treatment teams and equipment ready to go for your arrival. With that being said, it's patients are suspected of congenital defects, specifically congenital heart defects, need to be going to a comprehensive pediatric center. This is not a patient you're going to want to transport to an outlying community or a rural care center. Flight may be required for these if you don't have one near your area, and you should be familiar with the hospitals in your area so that you can have these patients arrive at the appropriate facility to receive the appropriate care. So congenital heart disease is the most common birth defect, and it can present with varying degrees of cardiorespiratory compromise. They will all have some form of cardiopulmonary compromise. We generally divide it into two categories. You have acyanotic defects and then cyanotic defects. Cyanosis, right, is going to be tough to detect in a neonate. But the detection methods we're going to use is going to be predominantly measuring oxygen saturation through pulse oximetry. Continuous monitoring is going to be important here. It's going to be hard to determine cyanosis because the prevalence of the bluish color is not great in the neonate, and all babies are somewhat cyanotic for at least a period of time post-birth. Non-cyanotic diseases are called pink defects. This is where oxygenated blood is shunted from the left side of the heart to the right side of the heart. This is called a left-right shunt, and it includes things like ventricle septal defect, atrial septal defect, and PDA or patent ductus arteriosus. All right, so let's talk about the patho of some of the congenital heart disease. One is an atrial septal defect. So this is an abnormal opening or a hole or defect in the atrial septum that separates the atrial chambers of the heart wall. We also can have ventricular septal defects where there's an abnormal opening exists in the wall separating the left and right ventricles. As we can see, this poses a problem with the commingling of oxygenated and deoxygenated blood. The patent ductus arteriosus is where the ductus arteriosus remains open and doesn't close after birth. If left untreated, this can cause heart failure. Ultimate treatment for this is going to be surgical, but supportive care and recognition is going to be important for the prehospital provider. Coarctation of the aorta, or COA, is a narrowing of the aorta. It can be associated with other cardiac defects. It's often asymptomatic until later in childhood, but it's something to just be aware of and recognize it's out there. Cyanotic disease is where deoxygenated blood from the right side of the heart mixes with from the left side of the heart, and this is known as your right to left shunt. You can see the ventricular septal defect there in between the left ventricle and the right ventricle, causing mixing of oxygenated and deoxygenated blood. Pulmonary stenosis is where the pulmonic valve near the right ventricle becomes damaged. The patient will often present with jugular venous distension. This is a cyanotic disease, so low SpO2, and can present with right ventricular hypertrophy. Truncus arteriosus, this is where the pulmonary and aorta arteries are combined. This causes increased blood flow to the lungs and, again, ultimately will require surgical intervention, but you can see that it creates a mixing there, again, of oxygenated and deoxygenated blood and ends up recirculating oxygenated blood back to the lungs, which can pose some complications. Another to be aware of is tricuspid atresia. This is where the tricuspid valve is missing. It results in an undersized or absent right ventricle, and they'll have decreased blood flow to the lungs, again, with hypoxia being the main concern here. Hypoplastic left heart syndrome. This is where the left side of the heart is completely underdeveloped and unable to fulfill. For this, long-term treatment is going to be a heart transplant. Tetralogy of Fallot is a combination of 4 defects. You have the persistent ventricle os, or the ventral septal defect, pulmonary stenosis, right ventricular hypertrophy, and an overriding aorta, and open heart surgery is going to be required for this patient. TGA is transposition of the great arteries, and this is where blood goes to the lungs and then returns from the lungs, and blood from the body goes to the heart and then returns to the body. It's a transposition of the pulmonary artery and the aorta, where the aorta is transposed. Total anomalous pulmonary venous return, or TAPVR, is 4 pulmonary veins connect to the right atrium instead of the left atrium, and this results in diminished oxygen and increased load on the right ventricle. And as far as assessment and management goes, none of these are going to be fixed in the pre-hospital world, but these are complications that can exist. Your job as a pre-hospital provider is to recognize the persistence of cyanotic diseases, right, where the patient is not adequately perfusing, ensuring that these patients are going to the right facility, and making sure that we don't delay in that continuum of care. These patients, early recognition and detection for these birth defects are going to be important to the ultimate survival for this patient.